Hi, everybody. Happy Hump Day. Usually I do my baby Fridays, but with Mike's schedule, we kind of shifted it a day. Um, so I'm seeing some people. I preloaded some links on the LinkedIn page there for y'all to look at and to go back and reference when we're done on the No Surprises Act. And I'm seeing some people asking people to give some shout outs. So Jessica is coming in from Seattle. We have somebody in from Idaho. Ooh, I bet it's cold there. And Maggie from LA, not cold there, I'm supposing. Lisa from Lincoln, Nebraska. Kimberly, hey Kimberly from Garland, Texas. How you doing, Kim? And then Mary from another Washingtonian, I think, is the Kettle Falls, Fort Myers. So good. We're getting a lot of good people dialing in. So I would like to welcome, and I'm really pleased again to have my friend Mike Sacopulos back. We had a little bit of an issue the first time we did
gremlins. We had gremlins, but we're all
so
good.
Mike is back, and he is a healthcare attorney, and he has the Medical Risk Institute is what he is involved with on the medical side. I'll put his logo up there so y'all can take a look at it. And we are going to talk today about the No Surprises Act. The surprise was not a good one for us on the physician side. So we're going to walk through some stuff because people are really, really struggling with the No Surprises Act. And before we talk, get to speaking, what I would ask everybody, if you have questions for us, since there is that delay in the time y'all type it into the time we see it, while Mike and I are speaking about the act before we take questions, if you have questions, go ahead and put them in now. And that way it'll be in the queue so that when we get to our Q&A, we'll have it already up there for you and can get to answering as many questions as we can get to before our time limit runs up today. Mike and I will be doing the broadcast here till noon. So we've got an hour here that we're dedicating for y'all. And I'm sure all the questions aren't going to be answered in that time because of all of the confusion and problems with the NSA so far. So Mike has graciously agreed to do a webinar for us also. So that is something that once I get the CEU approval from the AAPC, so it will be CEU value. There'll be one CEU. It'll be an hour-long webinar. We'll put some notices up about it, so be watching for that. So whatever we can't get to today, maybe you can watch the webinar or, come in and attend and get some more questions answered. So, Mike, thank you for joining me again today. Happy to have you back.
Always a pleasure. Thanks for having me.
Oh, yes. And so what I've done is I'll put a couple little things up as we talk about them so that everybody can kind of see where we're looking. So the first thing I want to talk about with the No Surprises Act that I noticed that some people don't realize is that this isn't new. I mean, federally it's new, but, states specifically have had their own No Surprises Acts for a while, at least some of them. So can you address, some of that where some states are coming in?
Sure. So it's a really a mixed bag. There are 18 states that have what I think we would all consider kind of full on No Surprise Act. All of this came before the federal act that we're going to spend most of our time talking about. And so there are 18 of those states out there that have full-on No Surprise Act, and then there are another 15 states that have bits and pieces here and there. So that's the majority of states that have something on their own. All this just makes it more complex when you layer the federal new law that we're going to be talking about that just kicked in here at the first of the year on top of individual states' requirements. And of course, we have providers that will see patients in different states, right? I mean, health systems or a practice that may cross a state line. And so you have to comply with where the patient is. not where the home office of the practice is. I've got some clients that I'm thinking of one that's a dermatology practice that has 5 or 6 locations, but they're in 2 states. They're on close to a state line, and so they would have to comply with both state laws as well as the federal law. Now, thankfully, the federal law um, covers much of what state laws do, so they're not totally separate, but it's way beyond the scope of what Betty, you and I can do today to talk about 18 different states full-on laws and 15 others partial laws and the federal law. This is all just to say it is a big, it's a big regulatory knot. So
Okay.
we're going to try our best here to work through it. And if you're compliant with the federal law, that puts you in pretty good stead for the states as well.
So the question I have coming with that is, now that we have the federal law, does one trump the other? Is like one, you know, if the state's more restrictive, do you have to go with the state, or do you get to choose?
Yeah, so that's a great question, and we've seen this in other areas of healthcare law too. Patient privacy, for example, where HIPAA's provides one level, and then states have certain privacy rules on top of it. It makes it confusing, but here's the general rule: the federal laws are the floor, that you can't go less than what the federal government says. But if a state requires something above or in addition to or more restrictive than the federal law, then you have to comply with the state. So the federal is just the baseline, the absolute minimum, and then states can amp it up from there. Drop down timelines. If the federal timeline says 30 days, a state can make it 15 days, and then you're stuck at the 15-day level, for example.
Okay. Kind of like CMS with their NCDs, and then a MAC can make an LCD, and you have to follow that pay or what they're saying. So
that's
it's kind of
a
like
great analogy. Thing. Yep, absolutely.
Okay. All right. So for those of y'all that are watching in today, make sure that you're checking on the state issue, because as Mike said, there's 18 states that also have it. So make sure that in your state, there's not something more restrictive that you maybe have to do now.
Right.
All right. And then now the big, you know, the one that we're going to talk about most is the federal one, the new one for the NSA, the No Surprises Act. Was that brought about mostly from like patient advocates? Or I know the American Hospital Association is like, I think it's a good thing too, and blah, blah, blah. But, you know, the big push to it, you know, where did that come from? Do you know?
So I think you're right that there were some patient advocacy groups out there. And I will tell you that the number one cause of bankruptcy in the United States are medical expenses. So as people have higher deductibles and so forth, their insurance coverage, people are finding more and more exposure, and certainly these out-of-network charges. Look, no one is a bigger physician advocate than I am, Betty. You and I are. I mean, this is how we spend our life, and all my friends are physicians, and this is what I do. But I have to acknowledge that there are definitely some pirates out there. People that put on the eye patch, fly the Jolly Roger, and charge like 20 times what they should, and that has caused problems. Certainly, in surgical situations, really where if you really want to see some full-on pirates, and I know this is not our audience today, so I feel free to just lambaste them in great detail, are these ones that fly the helicopters. You know, they fly in, they take the patient to the 20 minutes over to the hospital, and they hand over a bill for $48,000. I mean, these are the kind of things that were going on. In that, I think it doesn't take too many of these kind of outrageous situations in all these bankruptcies for somebody to say, by God, there ought to be a law. And that's what I think triggered it. Unfortunately, what we got is something that is wildly complex. And if our audience is confused, I will raise my hand and say that I've spent hours and hours trying to go through this. And I think I understand it, and I'm glad to try to help people. But it is far from certain that everyone can understand it, and our interpretations are going to be solid in the long run. There are a lot of unanswered questions on how things work. And so I think we can talk about those as we go. But as far as an impetus, I think it was a mix of patient advocacies and people just being horrified by some real pirate behavior.
Yeah. It doesn't take, the whole one bad apple spoiling it for everybody else kind of thing. But the main part of the No Surprises Act is that whole surprise medical bill thing where you have an emergency situation, you go to a facility that you think is in network, but some of the people that are there are out of network, like the physician group that staffs the ED or the radiology group that reads the x-rays and things like that.
The radiologist or the pathologist that you never meet, and all of a sudden you find out that the hospital was in network, maybe your surgeon was in network, but the pathologist, deep down in the bowels and the basement of the place, was out of network and is now charging you in excess of what you would have been charged had that pathologist, he or she, been in network.
Or anesthesia. That's also, if you have to pay that out of pocket, that can get pretty hefty.
That's right.
So I think, again, for most of our audience, that's not, they're not staffing hospitals like that and doing the out of network kind of things. Most of them are, physician practices that are like, well, I don't really think a lot of this applies to me because we have, this, at an in-network facility, but I'm out of network kind of thing. And so I think that's where some of the surprise to the physician groups kind of came in, because they were thinking, well, that really, I'm not going to have to worry about that too much. But the part that really came in as the big surprise is, the good faith estimate, the GFE. And I think that's the part for physician practices that they're more going to have to deal with than the no surprise part of the No Surprises Act. Do you agree with that?
I do. I think that our audience today probably is the mix of people that really have to affect it. The good faith estimate comes in when a patient is not going to use their insurance coverage, right? Either you don't accept coverage, or for whatever reason, there are a few kind of obscure areas of medicine where people just don't want their insurance company to know. Let's say it's a mental health issue. I don't think that that's our audience, but you can imagine that there are some times that people don't want to use their coverage. And there are a lot of times that coverage just doesn't apply. Let's say it's an aesthetic procedure. They're going to get some Botox or a blepharoplasty or something like that, and there's just no insurance coverage for that because it's aesthetic. That is the situation where people are going without any coverage. That a good faith estimate has to be given.
And in the act, they describe, because I've had this question where sometimes people get confused, is that they say it's for self-pay or uninsured, and so people are like, well, isn't that the same thing? And that kind of alludes to what Mike was saying, is that it's for either people who don't have insurance or for people that have insurance but don't want to use it or can't use it for whatever the procedure is that they want. And so that's really, what the government is kind of using those two terms to mean. So basically it's for any patient that is not using or doesn't have insurance, and is having procedures performed, right?
Yeah. Anytime there's not going to be a third party payer involved, I think we're looking towards, for whatever reason, right? The patient decides he or she doesn't want to do it. They were involved in an accident and their attorney's telling them, don't turn it into your insurance. The other people are going to pay. Whatever it is, if it's not being billed to a third party, then I think you need to be focused in on providing a good faith estimate.
Okay. And then now I'm going to share my screen with some things that I brought up that'll help us and help us point to some specific things for people to kind of watch for with the No Surprises Act. So give me a second here. Okay. Now, here, this is just one that when I was looking at this now, in part of the resources that I listed for people, it does have these in there. So you'll be able to go back and pull these up for yourself if these are things that you say, hey, I want to look at that again. So in the resources I put at the beginning, for those of y'all that are listening and watching, you'll be able to access these. But this one was one of the appendix that they put in, one of the appendices. The government was kind of saying, we know that there'll be a slight physician burden for these things. And anytime the government tells you there'll be a slight burden, strap on your boots because,
Exactly.
It's going to cost you.
Yeah. Spoken like someone who's trillions of dollars in debt. Yes.
Yeah. So in this one, this is one of the appendices that is in the grouping of the stuff I sent you. It's supporting statement part A, when they're taking a look at what it's going to cost and things practices have to think about as far as costs go. So the first one, they have the adjusted hourly wages used in their burden estimate. So the government is putting out here what they're estimating the hourly rate for all of these people that are going to have to be involved in the No Surprises Act for the physician practice kind of go through. So whether or not it conforms to what your hourly rates are for these people, depending on what area of the country you're in, it may or may not. So you see they break it down from, administrative, like secretaries and lawyers and computer programmers and human resources and business operations. It goes kind of through all of them and then lists out hourly what their compensation rates are. Again, the government's estimate. And then what the total hourly cost when they also add in overhead, which is something, again, when people are budgeting for things, sometimes they don't think about. So you also have to put that stuff in and remember, there's going to be overhead involved in all of this also. But here where the figures, I started looking and was like, oh, you get that sick feeling in your stomach. There's the one-time cost, because sometimes people, I think, may have missed the fact that posting a sign up in your office is great and you're supposed to do that. But you also, if you do have a website, it has to also go on your website. And
exactly right.
It costs
That's exactly
to
right.
do that, So here they have the one-time and hour burden for providers associated with facilities. So they're saying if you're an employed physician, that your burden will be less because the facility is going to bear some of that cost for you that, you might not have to. Depending on what kind of facility that is, they may say, hey, this is your thing. You guys are responsible for doing all this. So whether or not this is going to be true will depend on those factors, I think. But the thing in here I wanted to point out was this right here in the middle, burden per response. So that's every time you have to answer and give a patient a GFE. The government's estimating that it's going to take 4 hours to do that. They also estimated in here that they estimate that the average GFE is going to be at least 4 pages long. So that's a lot of work if you have a lot of cash and carry stuff in your office or people that don't want to use their insurance for something. Every single time you go to do one of these, 4 hours.
That's right. And Betty, let's pause here, because I think you and I have both spoken to our clients that say, hey, we already let people know what the cost is going to be of a procedure, right? So we're telling, and that's nice and that's great that you're doing that, but it doesn't mean that you are complying with the law, because there are specific forms and specific types of information that have to be given, I think, far more in depth than what the average person is thinking. And Betty, I don't know if you agree or disagree with that, but I don't want people to be lulled into this. Well, we tell people in advance what the cost of the Botox is going to be, therefore we're compliant with the act. Maybe, I mean, you're moving in the right direction, but I don't think you're all the way home.
Yeah, because in the act it says that you have to give it to them in writing or electronically, somehow. So either sending them an actual paper form or emailing them the paper form. You have to fill out and meet all the criteria in the GFE to cover yourself. So just telling patients what it's going to cost is not cutting it.
That's right. You want to make sure that you're using the appropriate form and complying. The other thing with these is that there's timelines of how far in advance you have to give people these estimates, right? So
Yes.
just because you've told somebody, that doesn't mean that you've given them the appropriate amount under the federal statute of time in which to consider or whatnot. So
Yeah.
it can't be same day, right, Betty?
And that was one of the things that I saw that people had issues with, was that, well, we see our patients 2 or 3 weeks in advance and we schedule them then for these things. So if we give them the GFE then 3 weeks ahead of time, it's not good. It can't be that far out. It has to be done like, is it 1 day or within 3 days
Three
before the
days
procedure?
generally. Yeah.
So what are you going to do? Have them come back in to go over it with them again? Again, then you're looking at staff time and all of those issues. Or you're going to email it. How do you make sure, if you're going to email it, that the patient received it? So do you have to put read receipts and then track them for everything? Because what if they say never got it?
Right. Yeah.
So, and here in this, going through their table 5, they've estimated the one-time cost and hour burden for individual practices, physician practices, to draft and post. This is just the notice, not the actual GFE itself, but just to do the notice for it. They're saying the burden response is going to be 2.5 hours for that. Additional for subset of physicians within the website, another hour, so they're estimating 3.5 hours just to get it onto the website. And excuse me, the cost using their other figures about wages is going to be $75 million, over $75 million to the practices. So, and you're not getting anything back for that. There's like no upside to this. This is all going to be adding into overhead costs for physician practices, right?
You don't even get a thank you.
Yeah.
Nope. You get Zippo on this one. It's just an overhead expense, unfortunately.
Yep. And then here's the posting the notice again, 3.5 hours, $50 million. Estimated time cost related to the notice of the right to a good faith estimate. We're looking at 15.5 hours to put it all together. So, y'all can kind of look through these, but as you look at these hours that they're saying these things are going to take and what the overall burden and cost is going to be, and then mail, if you mail it, they were adding that in too. So it's a good kind of wake up call and may help you think of different areas that, that you may not have thought of as far as budgeting and trying to figure out how much all of this is going to cost you. So it's something that was pretty eye-opening to me, when I started looking at these figures. And the government, I believe on their side, they said it was going to cost them like $6 billion to, do all the stuff that they need to do with getting the IDRs and the SDRs and whatever. So, it's not going to be at a no cost to CMS either. And in putting in practice things like that, where's that money going to come out of was my other thought. If they're paying for all that portion of it and doing their side of it, they're probably not just going to eat all that. It's probably going to trickle out in some other ways to physician and hospital burdens.
And one of the things that I think may not be covered in their list of expenses is the education of your staff on all these new rules, right? I mean, it's one thing to take time to put the notice up, but your people have got to understand how these laws work and how they're going to impact the practice and keep up with all of this. And that is an internal educational cost that also, unfortunately, you're going to have to to bear without additional compensation. I know this is especially for our folks on the West Coast in Seattle and in LA this morning. A difficult thing in that you can't do with and it's too early to have a stiff drink. But that's the news that we bring. I'm sorry to not have happier news here, but this is, and I think where Betty's going with this is a huge burden upon practices, not only financially, but in terms of staff time as well. And so to get compliant, I think you need to schedule things out and take it bit by bit. It's the old, how do you eat the elephant one bite at a time? And I think I think that's kind of where we are, because there's a lot of different moving parts here. And so we just need to be methodical and work through the act and get compliant.
Yes. And now here I brought up, this is another one of the appendices. And I did see some people are making comments that they were getting in on their laptops and don't see the links I put up. I will post them again. But if you look at the very beginning of the broadcast, when you come in the comments, at the very beginning of the comments, I put in the links there. But yes, I will go ahead and load them again for people if you can't find them. But what this is, the government, made a template here that is for use for the GFEs if you don't have one drafted up. But the funny thing to me was when the government put it up there, it said that it's not compliant with what the NSA said, but it's okay because they said that they will accept it, anyway for now. So make sure, that you're going through, and before they put this up here in this template, they have another one that has, I think it's 6 pages maybe, of all the requirements that have to be in a GFE. So, you have to go through that and make sure you are hitting every single point in there, and that all of those points are in your GFE that you give to patients.
That's exactly right. And that's why I was saying earlier, and I think you were too, Betty, that people that think, well, we tell folks what the cost is going to be. That's not going to be sufficient, obviously, if it's a 4-page form. You've got to go through.
And you can see here, when you look at it, it's got the standard stuff about their address and all that kind of stuff. And then how their preferences, did they want it by email? Did they want it by mail? But they expect you ahead of time, just like pre-auths. And we know how much trouble patients or that practices have with pre-authorization. Something they want every CPT code, every ICD-10 code, and you just don't know because other things can happen. That is also something that's required on the GFE, is that you put in the primary service, the primary diagnosis. They want the CPT codes. They want all of that stuff listed on the GFE you give to the patient, which for a lot of patients, they're not going to understand the ICD-10 and the CPT. So it's just going to beg further questions from a patient. So you're going to have to spend more time now explaining coding, and what those things mean and what those numbers are and things like that. So I just see that as, again, an extra time drain that maybe people weren't taking into consideration. And then giving when the estimate was given and what the total costs are. Now, Mike, you brought up an interesting thing before when we were chatting. There are these extra pages here for the provider. And I know this one's changed. Let me turn there. So provider and facility 1 estimate with where they're going to have the procedure and where it's located. Again, the codes and the CPT and ICD-10 codes and what the facility's expected charges are. And then facility 2. So if you're going to use the anesthesiologist, if you're going to use, a radiologist services during it, that who's expected to give all that information?
Well, come 2023, the provider is expected to be able to cost out the entire procedure for the patient. So this year, 2022, you only have to do what's going on in your office or your services. But come 2023, you've got to give the patient the entire estimate. The facility, if you're doing it at a different facility, let's say you're doing a case at a different facility, you've got to give that facility built in with your own, built in with the anesthesiologist, if there's any radiology, so forth, any kind of drug cost, all of these kind of things add in so the patient has a global understanding of what he or she is going to have to pay. That's not easy, right? Because you don't know all these ancillary people. And then, Betty, you're going to tell us what happens if we miss our estimate, and it's not pretty.
Yep. No, and that's the other thing too. You know, the co-surgeon, that kind of, you know, if you're using co-surgeons, what there's going to be, and all of that kind of stuff. So just adding to what that office is going to have to do, and it's the responsibility of that primary surgeon or practice's office that's offering the service for the patient to handle all of that extra stuff. That's just crazy. Yeah. But that's the government's act, you know? So here's this is the end part of what this templated form is that they give you for patients. And here's the part that caught my eye, is that if you're billed more than this good faith estimate, you've got the right to dispute it. Now that's part of the act. And that is including complications. And that's the part that, another part that I'm having trouble wrapping my mind around.
Yeah, it's so mind-bending.
Give the patient a GFE and you say, here's my estimate. Let's say it's $2,000. So we have even math, right? But that's barring any complications. But let's say they have a complication, or Mike, you were stating the non-compliant patient. And right. So it ends up with issues. And so that estimate is just blown out of the water. Even at that point, the patient has a right to dispute it if it's $400 over what your GFE was that you gave to the patient, right?
That's right. And we can all imagine there are not a whole lot of complications that are going to be under $400 all in, right? Yes. So this is going to, anytime that there's another issue that was unanticipated, would almost by definition fall into this category, I think. Yes. And so, Betty, tell us, what does it take for a patient to file a dispute?
Yep. It's going to cost the patient $25 if they don't like the bill that they received that was over your GFE for whatever reason. So here is the other part I wanted to, you know, make sure everybody is seeing. Let me turn my highlighter on. So I already said, if you're billed more, this is what it says, right? So you may also start a dispute resolution with the U.S. Department of Health and Human Services, so with HHS. If you choose so, you must start it within 120 calendar days. So you got 4 months to say, you know, I'm not agreeing to that. So a patient cannot pay you for 4 months saying they're disputing it if it's $400 over. So they have a complication or they're non-compliant and you do all this extra work. Now the patient can say, no, that's over my estimate. I'm not paying. And you're going back and forth. And let's say you put the patient in collections even because of this issue. So here is it telling you there's the $25 fee. And then, you know, it goes to the SDR, the dispute resolution people. And if the agency disagrees with you and agrees with the healthcare provider, you'll have to pay the higher amount. But if they don't, you only have to pay the GFE amount. So then they're not responsible for that other cost. But the bigger issue, Mike, and I would like you to speak to this from that aspect, is during, you know, this time, let's say the 120 days is going and they're not paying their bill, and you've turned them in to collection agencies or you've done that kind of work. Now they're saying, okay, I dispute it. So they've waited 4 months. Now they dispute it. What happens at the practice level?
So here's the problem. Once they dispute it, you cannot go forward with collection activities, either in your own office or if you outsource it to a credit bureau collection agency, they can't pursue it on your behalf. Now, remember, we're 120 days out. So lots of practices have long since turned it over. They've attempted to collect at the time. They've sent a letter or two. 30 days goes by, 60, around 90 days. They kick it out to the collection agency. The patient contests it, and now you have a violation if that collection agency continues to go after the patient. And most collection agencies, that's what they're geared up to do. Can you recall these patients once you have it? Yeah, you can surely try, but I'm here to tell you that I've had more than one experience with collection agencies just keep going because it's in their data bank. Their collectors are all compensated on a percentage of what they bring in basis, and it is not so easy to withdraw claims from a collection agency. So you've got to be careful because you're going to be in violation of the No Surprises Act. That's one. But there's also pursuing a patient for money that they may not owe is a violation of some credit standards. If it's posted, there's a Fair Credit Reporting Act, which you could be in violation of. You can also, under the consumer collection laws, have problems there as well. So one problem gets you into multiple other federal acts which have penalties and attorney fees associated with them. I'm telling my clients, do not turn people into collections before the 120 days because it could cause you all kinds of problems trying to stop that procedure. If they drop off their $25 in the federal, go on the website, pay their $25, and then you have to stop. That's going to be an administrative nightmare. And so you might want to wait to turn people over until after that 120 days so you don't have to redo something.
And that comes too with some of the collection agencies. They may turn, it into your credit report too, right? And then that's an extra layer of trying to pull that back, right?
That's right. That's right. So then you have, problems several degrees out of not only getting the collection agency to do it, but then to get a different credit bureau. Oftentimes, as we know, there are multiple credit bureaus, right? And it can be
Right.
turned into several different ones. Trying to take that off during this dispute resolution period, you're going to have all kinds of effort and expense for turning someone over, and then all they have to do is pay their $25, go online, and it can cause you lots of grief. So that's why I'm saying, to be safe, I don't like the idea, and I fully understand that the older accounts receivables are, the less likely they are to be paid. We all know that. That's a general rule of business. Doesn't have to just be medicine. The older the accounts, the less collectible they are in general. And I am telling you to let these things age. I fully understand that that comes at a financial cost, but I'm telling you that the liability for not waiting the extra 30 or 45 days, in my mind, outweighs the money that you're going to lose.
Yeah. Yeah. So you're going to have a lot of practices that have ARs that can get really out of balance here quickly. And that's something else that you got to take into mind on the practice side is that, yeah, your agings are going to start to look really bad if you're doing a lot of these and you have patients that are just holding out, and then saying, okay, I don't like this. And, so now it's already aged out 120 days. So it's really going to start to affect balance sheets and things like that and how the practice looks on the books,
And
and then,
Betty, let's be honest, we don't know when somebody pays their $25 into the government to dispute, saying that the good faith estimate wasn't accurate, how long that process is going to take. We don't have anything to look at right now. Is it going
right.
to be a 15-day turnaround? I kind of doubt that. I think it's going to take longer. But we just don't know how efficient that process is going to be. And
Yeah.
so I will not make any skeptical comments about the efficiency of our federal government. I will let you all determine that on your own. I'm just saying that at the 120-day mark, if they contest it, we don't know how far beyond that it's going to be
Yep.
before you get paid.
And then the last thing I wanted to show before we take questions is this was an article that I saw this morning, which I thought was, well, hey, that'd be a good thing to bring up, is that MGMA, the Medical Group Management Association, they have asked HHS to delay the No Surprises Act, but, it's already started. But looking at this article, it talks about how, practices are struggling and, things. But here was the thing that caught, again, my eye, is that MGMA did a survey. And in the survey, that 90% of medical practices have experienced an increased administrative burden. Big surprise with looking at all those things you were talking about, right? So this is really hitting every practice. 90% of the practices are saying that this is a problem for them since the act went into effect.
Yeah, the other 10% just don't have the metrics to measure it.
Yeah.
Everybody's been hit by this. So
yeah.
Yes, absolutely.
And they're talking about, of course, the Omicron now and the staffing shortages, and this is just adding, with that burden. But the interesting part when I got down to the bottom was CMS, they said, we've released all, those 11 documents to help you out. And then they, have just not even responded. So they've kind of gone silent on this issue now. It's just like, we set it out there, we're done.
That's the equivalent of go fish, isn't it? When you're playing cards, put it out there. There you are. Good luck.
So, something to watch, but you can't bet on the fact that they're now going to come out and say, okay, we're going to put it on hold, and say, well, I'm going to, hang my hat on that. And I'm just going to hold off then, because it's enacted right now. So you can't wait for them to say, we're going to put it on hold. Right, Mike?
That's exactly right. So the law kicked in on January 1st. So you're to be compliant. Now, will something happen down the road and we kick the can down and timelines get pushed off? Maybe. But I'm telling you right now, if you are not doing these things, you are out of compliance and you could have liability because of it. So I would not bank on the fact that the rules will, especially given CMS's silence on this, having put it out there, that somehow this is all going to be magically suspended in the near future. Could happen, but that's a dangerous bet.
Yeah, kind of like when ICD-10 was coming out, and then it didn't. And then it didn't, and so practices a lot, because I spoke and was training, of course, a lot on ICD-10. And, that last year before it came up, everybody was like, oh, yeah, they're going to delay it again. And people were kind of caught, or the 2021 E&M changes. I'm still dealing with clients that were not ready for that because they thought, oh, it's not going to happen. We're in a pandemic. Well, it was in the Federal Register. They warned you for over a year, and it certainly did happen. So it's better to be ready, and now it's actually going. So you have to deal with what you have today, and today we have the NSA, right?
That's a good point, Betty, because I think so many of us look at it when the rule comes out and it's a January 1st, and this is all new to us. What we don't think about is how much time the government agencies have spent coming up with these rules and vetting them. And I've seen processes that have taken literally years, right? So the regulators at their end, it's nothing new to them. They've been working on this for 3 years, and they don't have any sympathy when somebody says, oh my God, this is brand new. What am I going to do? It just hit. They're like, where have you been for all these years? I know that that's not fair. I'm just telling you that's the regulator's mindset. And I've seen it time and time again, is that in their day-to-day existence, they've been working on this for many years, thinking about it, getting people's comment, going through all the different stages before it hits the regulation, all of which is off of the radar of the practice. And that, I think, is the disconnect. And so from that mindset, you could see why somebody would say, this is a big problem. We've been trying to address it. We've waited years to do it. We've got our solution. We've told you all it's here. Now you're just going to have to do, and don't pretend to be, just caught off guard. We've been at this forever and it's been a problem. And so that's why we have this issue, I think.
Yep. All right. Well, I am going to go. We have quite a few questions in the comment section. So I'm going to go up and start from the beginning and we'll see what we can get to. So Mike cannot see the comments where he's at. So I'm going to read through them and see if, which ones you can kind of get through here in the time we have left.
Great.
Vanessa is asking, can you suggest resources for operational processes?
So I'm unaware of EMR systems having this integrated in as of today. There may be, and of course there are all these different EMR systems. So I don't want to say that in a blanket form, but that's where I would first check, because a lot of this procedurally should be through your EMR software and your practice management software. As far as people coming in to help set up flows and notices and so forth, people like Betty and myself do that. There are other options out there as well. But you're right. Operationally, there are going to be a number of different issues, and part of that, and I think a large part of it, is training staff to understand what the rules are and having some flow sheets to train people. Everybody that you have, I think, wants to do the right thing. This is just a confusing act. And so beyond having the right form, you have to have your staff know which form to give and when to give it. And I think that is probably what your question is getting at on an operational standpoint. And I think that it is a challenge. I understand that.
Yeah. Okay, Donna says, so if a patient chooses to have a colonoscopy at an in-network provider and that in-network provider chooses an anesthesiologist that is not in the patient's network, is the patient responsible for the anesthesia's bill?
Yes, but that bill will be, they certainly have to pay for the anesthesia. The question is going to be, how much do they have to pay, and what type of notice has to be given to them. And I think here, if it's an in-network facility, and let's say your practice is the one that is the physician doing the colonoscopy, it's going to be a burden on the anesthesiologist to notify the patient of this. So if the patient's in network and you're in network, then you're okay under this No Surprises Act. It's the people that are out of network that have to deal with the federal law now, and state laws if those apply.
And then the facility where they're having the procedure done will have to have notices up that state about the no surprise part, and they will also bear a bit of the burden for notifying the patient that they've got out of network, that not all providers are in network, and that kind of thing may come into play.
Exactly.
Jessica says, so this does apply to physicians' offices then?
Yes. It does. And let's take it one step further, because I think that there's been some confusion, at least with some of my clients, that say, look, we're an aesthetic practice. We accept no third-party payer money at all, right? And I think what's going through their mind probably is like HIPAA, where they're saying, if we don't do any kind of billing and we're not taking any money from third parties, then that law doesn't apply to us. And I'm telling you, that's dangerous, and it's not true. This law applies to every provider. Whether you accept third-party payment or not, you must comply with the No Surprises Act.
Because she put, we have providers that think it's only for hospital-based services. And that goes back to what we said at the beginning. I was finding the same thing, that people were concentrating on the emergency no surprises part, not on the secondary part with the GFE that our base is more affected by.
That's exactly right. And there certainly are laws that will only apply to healthcare systems or emergency rooms. I'm thinking of EMTALA, for example, as one law, and that's probably beyond what most of us are dealing with because we're dealing with providers and physicians and practices where something like an EMTALA doesn't. But put all that out of your mind. There's no place to hide with this No Surprises Act. It is
Yep.
comprehensive both at the healthcare system and in the individual physician's offices, whether you accept insurance or whether you are completely cash pay. It doesn't matter. This act applies to you.
Diana says, so the GFE is only applicable if the provider is out of network or the patient chooses not to go through their insurance, correct?
So kind of, you're almost there. The good faith estimate applies if a patient doesn't have insurance coverage or is not going to use or is not able to use their insurance coverage. If the patient is taking on the full burden of the cost, him or herself, then the good faith estimate applies. If the patient is using an out-of-network provider, but is still turning it into their insurance company, still going to get some benefit, then the good faith estimate does not apply. So it's not an in-network, and that's the problem with this act, ladies and gentlemen, is it is like multivariable calculus. There are
Yes.
all these different parts to it here. And so when we get to good faith estimate, what you need to think of is the patient fully 100% taking on the burden of the cost of this? And when you move over to the other part of the act, you're talking about in-network, out-of-network, where there is some diminished insurance benefit if the patient is out of network. If there's any insurance involved at all, then we are not in the good faith estimate category. We don't have to worry about that. But if you're out of network, you've got to deal with the other part of the act. So it's a bit of a balancing trick here.
It's going to catch you one way or the other.
Catch your coming or going. That's right.
Okay. Oh, Lisa has 3 questions. All right. So let's see what we can hit here.
Lisa, that's shades of law school when they call on you and they say I have a question that comes in 3 parts. I'm breaking a cold sweat. Okay, Betty. Let's work through Lisa's question.
Okay. What if a service changes? Example, screening colonoscopy turns diagnostic and polyps are removed. Provide the updated quote at the time of coding. Okay, so pulling on that piece of it, again, the only time that you would have to think about this is if the patient is bearing the cost themselves. So if the patient has insurance and you're dealing with the screening colonoscopy turning diagnostic, then this whole GFE thing doesn't apply.
Then we don't have to worry about the good faith estimate. And that's true whether you're in network, out of network, right? If it's getting billed, which I would imagine many colonoscopies. Here's the other thing that we should have mentioned, or I should have mentioned earlier, is that the No Surprises Act does not apply to patients that have benefits from the federal government, Medicare, Medicaid.
Right.
That's all excluded, doesn't come under the act. So this is really third-party payers, and Anthem Blue Cross, Kaiser, you name it, these companies, not Medicare, Medicaid.
But on the GFE side, if it's a Medicaid patient that says, I'm just going to pay for it myself, now you still have the GFE to worry
Exactly.
about.
Now we're not involving any kind of pay at all. And so
but Lisa's next thing is a really good question. And to be quite honest with you, Lisa, it didn't hit my mind yet. I'm sure it would have eventually, but Mike, same with you probably. It says, what if the insurance that the patient gives happens to be not effective after the claim was filed and now they are self-pay? How do we approach this with the GFE, or is it required since they presented with insurance or thinking they had insurance?
I've not come across this. I think Lisa's got a great question. I think that it's only fair if you don't know, if the patient's giving you their insurance card and saying that they have insurance, then you shouldn't be asked to give a good faith estimate, because otherwise you would have to give it to every last patient, right?
Exactly.
And clearly that's not the law or the intent. So to the extent that someone gives it to you and you're going forward with the idea that they have coverage, and later learn, my thought is that once you learn, you may be forced then to give a good faith estimate as to the remainder of the care. If there's follow-up care, let's say you did a procedure and now you've learned the patient didn't have coverage for that, but you know that there's follow-up care. There's 2 weeks out, 6 weeks out, whatnot.
Yeah.
That may kick in. It's an excellent question, and I
Yeah.
think what you're getting at is something that the law has not really thought through.
Yep. Yeah. Yeah. I don't, I don't think that's something that, has been addressed at all in that, and that I haven't seen it come up yet. So it'll be interesting to see. I think what'll happen is if, then you try to give them a GFE for the leftover things or whatever, and they dispute that, and it go, that then we'll probably start to see something come out about it. But I haven't seen anything about that scenario. So Jessica says, right now, we do estimates for any big ticket items, surgery, MRIs, EMGs, injections. Should we also be doing it on office charges for anyone not using insurance or without insurance?
Right. Jessica, I think that you should be, because the act does not specify at what dollar level you have to do this. So it would apply if you were doing a procedure in office, or if you were just seeing patients in office that were coming in for an office visit. Now, if it's a one-off office visit, that's pretty easy to do, right? It's not going to involve any other providers and so forth. But yes, it applies regardless of the type of medical care or the dollar amount associated with that care.
Well, and thinking about the office visit issue too, if you have a new patient that's coming, this is self-pay patient, and so for every visit where they're coming in, you're having to estimate, is it going to be a level 4 or a level 5, or so you're going to have to give yourself a little wiggle room, of course, because you don't know what the level is before you see them, so but yes, if they ask for it, or it's coming to also a point where even if a patient has insurance and they ask you for one, you still have to provide them with the GFE. I think that part is on hold, if I'm not mistaken.
That's
But
my understanding.
yeah,
Right.
but that's coming. So anybody is going to be able to ask you for a GFE in the near future here, and you're going to have to do this for everything if they are going to be like super picky about things, or all that kind of stuff. It could be for everything that's done.
That's right.
And so we have Diana that says, I would assume this is not applicable if services are rendered emergently, correct? Let's say the patient needs emergency surgery.
That's right. No good. At least the good faith estimate portion of the act, you don't have to do if the patient needs emergency care. The in network, out of network portion of the act would still apply, and specifically designed to hit these kind of situations where a patient has emergency needs and is out of network.
Yeah. So if you have, a patient that comes into the ED, and let's say they don't have insurance, and the ED physician is like, oh, they've got a hot belly, and it turns out that their appendix is about to rupture, the surgeon coming in, doesn't have to sit and go, here's the good faith estimate. Yeah. So
The 4-page estimate and wait 72 hours.
So
Not
yeah, so
necessary.
no, in the emergency situation, you're good. This is another one that I'm not sure I've seen specifically either. Mike, do you know if this rule applies to FQHCs?
Yes, I believe that it does.
Okay. And then Marie has asking about apply to government payors. I think we answered that. So no, it's not for government payors. Oh, and Mary. Hi, Mary. Glad to see you on. Mary says it does apply to FQHCs.
Mary's making me feel better about my answer. We're in agreement.
Yeah.
Mary and I are on the same page on this one.
Mary is an old compadre of mine. So she says organizations are trying to get the burden for FQHCs reduced because of the sliding fee scales and other methods to reduce patient costs. So that
Right.
makes sense. So hopefully
Sure.
there'll be a little relief for the FQHCs. And then let's see.
There is a ready, shoot, aim feel to all of this, right? That this was
Yeah.
put in, and now we're trying to go back and correct things like the that was just mentioned, the FQA.
Yeah, it's definitely like flying by the seat of our pants here. And and it's 12. I didn't realize that. So we still have some more questions, but we are at our end time for today's session. So we had some really great questions.
Great
And
question.
For some of the other ones, we'll try to, some of them are repeats about Medicare Advantage and Medicaid. So yes, those places
Right.
are exempt.
Betty, you have a sophisticated audience. These are the best questions I've gotten.
I know, aren't they great?
Yeah, you got smart people out there.
And so, yeah, so that is all the questions we're going to be able to take today. And I want people to know a couple other things. One, I did write an article on the NSA. It's going to be in BC Advantage magazine for the March for the next issue that comes out. So make sure you check that out. And I usually post those onto LinkedIn when I get them. So watch for that on my posts in LinkedIn too. And as I said earlier, Mike is going to do a webinar on the No Surprises Act. So we're getting all that stuff situated. So we'll put a notice out about that because it sounds like I was pretty much on, and so were you, Mike, with our client base being kind of confused. It seems like it's definitely carrying over with a lot of people having issues with this. So it's very confusing. And we want to make sure we're trying to help people out as much as we can. And if you want to contact Mike over at Med Risk Institute, here's his email information for some services with the NSA. Mike and I are kind of working together to put together a package for the NSA to help offices with things. So if that's, something you're interested in, shoot one of us an email and we can kind of get back to you on it. And the last thing is that my first healthcare happenings or healthcare highlights, I'm calling it, newsletter is going to be going out this weekend. So for those of y'all who want to get onto, the newsletter issues, things with my company, if you go to my website at chcs.consulting, you can subscribe to the newsletter. And if you do that by Friday at 5 Eastern time, you'll get the inaugural Healthcare Highlights newsletter. So make sure you're going over there if you want to, if you want to get in on that and make sure that you're up to date on everything that we're doing. And I want to thank you for your time, Mike. I really appreciate you coming on.
Oh, it's always a pleasure. Thank you for the opportunity.
And thanks everybody for listening.
Like questions.
What did you say, Mike?
I said, and thanks for the good questions.
Yeah, they were very good. We have I have a great base out there with the people with a lot of info and a lot of good things to think about. So thanks everybody for joining. And I will not be doing another broadcast this month. I have to take a little hiatus, but we'll be back in March. And I think my next guest in March is going to be an anesthesiology specialist. And I also have a physician that I'm going to have on that is an AMA author that has written a book about Medicare appeal. So he's going to come on and be a guest. So I'm getting some good people all ramped up for us to see when we come back. So thanks for your time, everybody. And we will see you soon. Thanks, Mike.
Thank you. Bye-bye.